Good evening. President of Calicut Forum of Diabetes, Dr. Kribal, Secretary Dr. Suresh, my dear colleagues and friends. First of all, let me express my thanks for having given me this opportunity to share my thoughts on the topic on which I was asked to talk. Well, this talk will be mainly on some aspects of PPA which are probably not highlighted much. As physicians, we all use PPA left and right. Okay, hardly a day without prescribing PPA. And these drugs are one of the most commonly prescribed and highest selling drug throughout the world, whether developed or underdeveloped. And you all know the most common indication for PPA was peptic ulcer maybe 25 years ago, but now no, because we hardly ever see any peptic ulcer when we do endoscopy, unless it is due to NSAIDs rather than that. The classic peptic ulcer disease is usually finished at the level of general practitioners. So most commonly what we find is gastroesophageal reflux disease, okay, especially due to the obesity. That's the current trend. People have a lot of truncal obesity and lifestyle changes, the type of diet which we eat, and the stress, etc. So GERD, I would say, is the most common indication for which we genuinely prescribe PPA. And of course, peptic ulcer is not an sort of gone entity. Occasionally we come across, especially NSAID. And for eradication of H. pylori also we have to use, because along with the two antimicrobials, we have to use a PPA for a better result. The next common indication is actually non-ulcer dyspepsia. The patient get a prescription for a PPA. The patient may not get good relief. You send the patient for endoscopy, and the endoscopy says everything is negative. You reassure the patient and prescribe again PPA. That's the usual habit. Okay, that's the current trend also. Most of us as well as you may be doing the same. So second major indication is actually non-ulcer dyspepsia, knowing fully well that there is no ulcer. Well, we can also say that there could be microscopic ulcers and all those things which is healing with the treatment. Then of course, when the patient is in ICU, an intensive care setup, for prophylaxis, we give PPA. And in high risk situation, aspirin, NSAIDs and other antiplatelets and anticoagulants. When the patients are prescribed these drugs, and especially if they have a prior history of ulcer disease, a complication of ulcer disease, or a GA bleed, we have to give PPA. So these perhaps are the real indications for giving PPA. Well, very often it's not the usual short term, 4 to 6 or 8 weeks. Most of our patients are on long term PPA. Why do we give? Because it's a very effective drug and hardly any side effect in routine practice, and prices become very affordable. So any drug which is taken by the patient, so even if you prescribe some drug for quite some time, after a couple of months the patient will come and ask you, doctor, can I stop it? This drug is very expensive. For example, patients taking aminosalicylate, salicylic and 5-aminosalicylate, various types like mesacola, they will come to us and ask, can we stop it, because it's quite expensive. Similarly, ursodeoxycholic, very expensive. So they will come and ask. But these drugs are reasonably priced, and therefore patients don't mind taking it. Second, they themselves will go and take it. Once they know that this is a drug which is giving them the effect, most of them will go to the pharmacy and buy it. On-demand therapy. So on-demand therapy for dyspepsia is very common among the patient group. Well, patients with the GERD, unlike peptic ulcer, require long-term treatment. So most of these patients are on months and years of, especially if they have a situation which prevents them having a surgery. Younger patients with GERD, it is ideal that they all go for surgery, because we have to maintain them on PPA for a long period of time, and we do not know what is going to happen to them. Okay, so elderly patients with a lot of comorbidity, we still have to continue give them PPA on an indefinite basis. And nowadays, PPA are prescribed, in fact, probably more than gastroenterologists, by different specialists, especially ENT. So anybody with chronic cough, anybody with chronic laryngitis, anybody with even chronic sinusitis, they get a prescription of PPA, thinking that everything is due to reflux or rather supraesophageal reflux. Maybe 50% of the patients with the so-called this chronic laryngitis, pharyngitis, etc. may be having reflux, but the other 50 actually do not have. And in ordinary clinical practice, there is no method to cross-check this. The ENT physicians or surgeons do laryngoscopy or pharyngoscopy and find out there is erythema, edema of this region and put this patient on PPA. And like other indications, these people, so large number of people are actually prescribed PPA for these reasons. Then maintenance therapy. People with ulcer disease who had a complication like a bleed, we put them on a long-term basis. And non-GI indication, people who are on aspirin and other NSAIDs. And it's a general habit that whenever we prescribe an anti-inflammatory agent, PPA is co-prescribed. Earlier it was ranitidine, but now it has been taken over by PPA. Okay. And of course, as Zollinger-Ellison syndrome, apart from the treatment of the primary tumor, we may have to give them a hefty dose for a very long period. And lastly, the sheer habit of co-prescription. This I would say, I actually scold my PGs every day. Every day I would say it is just like going to a hotel and checking in. In most of the hotels you get a complimentary breakfast. Okay, good hotels, 2-star and above. So whenever somebody comes to gastroenterology, the PGs will write some pantoprazole. I will say this is a complimentary prescription. Okay. So similarly, you go to dermatology, you will get a complimentary antihistamine. You go to ophthalmology, you will get a complimentary eye drop. This is our sheer habit. We just want to do something, so we prescribe. So we have to resist the temptation to prescribe certain things when it is not indicated. I would say a large percentage of PPA prescribed by us, including me, may not be really indicated. Because we don't think of anything else to give. So we just prescribe. That's it. So I think after every endoscopy, I have made it mandatory in my department that I'll go through the prescription given by the PGs and make sure that if it is, sometimes they even give double dose PPA. Okay, after they want to really stop the acid production. There is no ulcer even, but still that's a sheer habit. So we all have to get rid of this sheer habit. Okay, I won't go into any of the pathophysiology and all this stuff. Just know that proton pump inhibitors produce irreversible blocking of the hydrogen potassium ATPase. Irreversible blocking. Okay, then you may wonder how it comes back. No, the intestinal lining epithelial cells have a life only for 3 to 5 days, like your platelets. Once you block the enzyme system, for 3 to 5 days it won't work. Then it will be replaced by new sets of cells. That's why you have to give it on a regular basis, continuously, as long as you want to get the therapeutic effect. The earlier drugs for ulcer disease were anticholinergics. The persons like Dr. Balasubramanian and Dr. Nirmal Chandran must be knowing this. During our learning days, that was only available drug. In 1980s came cimetidine with a lot of fanfare, and soon we realized it also produced a lot of side effects as well. Then came in early 90s omeprazole, and then of course a series of all those drugs, different PPA came. Now, even though we all use this left and right, you must remember that it can produce a lot of side effects. Though not seen on a day-to-day practice, but prolonged use of PPA can produce a lot of side effects, and there is a very big list in fact. Okay, nutritional deficiencies, rebound acid secretion, interstitial nephritis, gastric polyp, cardiovascular risk, bone fractures, and infections. So I will briefly touch upon each of these because Dr. Kripal has told me my time is 20 minutes. So I will not go into great details. So when PPA is used on a long-term basis, you all know acid suppression will occur. Definitely there will be an acidity in the stomach, and acid is really required for the absorption of vitamin B12. So excess acid and no acid both actually affects B12 absorption. So a person who takes a normal diet and does not have any other problem may not develop significant B12 deficiency when taking PPA. Okay, but the elderly and the malnourished patient may be having a higher risk. So chronic PPA therapy was associated with a 46% decline in the median serum B12 levels and a subnormal level in 10% of the patient. It may be due to the fact there is additional small intestinal bacterial overgrowth also, because the gastric acid secretion is just like a sort of some security trying to prevent the entry of unwanted elements. So it will try to kill all the bacteria which is getting into the stomach. Actually, then you may wonder why some people develop enteric infection and other infection. It is because of the food. Food actually buffers the acid and make it sort of less acidic. So when we eat food, these bacteria can get in. That is how various noxious bacteria get in and produce illness. When there is less acid, there is a more propensity for bacteria to grow in the upper GI tract, especially jejunum, and these bacteria tend to eat up some of it produces a lot of things, of which one of mechanism is eating up a lot of B12 and may produce marginal B12 deficiency. And another thing, because of the same mechanism, supplementation may not work. Okay, but lucky is that clinically evident malabsorption and B12 deficiency does not occur. Many people may have subclinical B12 deficiency, and the clinical significance of this is not clearly known. Although there are some reports of some clinical entity due to peripheral neuropathy or spinal cord disease, etc., but clinically evident disease has not been described. Second problem is iron absorption. You all know for iron absorption acid is required. So when there is a suppression of acid, the same thing will happen. Okay. So here again, a person who is healthy having normal iron stores may not develop iron deficiency. But remember, many patients taking long-term PPI may be having additional problems. Especially elderly person will have age-related chronic atrophic gastritis. So elderly patient coming with the dyspepsia, for him also we will pump in PPI, but actually there is not much of acid in his stomach. So we are producing double damage. Okay, the little bit acid is also suppressed by us. So already they may have marginal problems due to anacidity and diminished iron absorption, and we will cut that acid level also. So there is more chance to have less iron absorb. Okay. Then another important problem. This is seen not very commonly. I haven't seen it. A hypomagnesemia. Maybe I have not diagnosed it. So from tomorrow onwards, if I look very carefully in a patient coming with the features of so much of symptoms like tetany, this, that and other things, and then look at magnesium level, perhaps I will be able to diagnose, because we seldom ask for magnesium levels, and therefore patients having vague symptoms, we put some diagnosis, and if you don't have any diagnosis, we will make it psychological and try to treat in that way. So I think this patient taking PP on a long-term basis, we should be careful when they have symptoms suggestive of tetany, muscular problem, breathing disorder, this, that and everything. Okay. The exact mechanism by hypomagnesemia occurs is not very clearly understood. There are major theories: impaired absorption, excess loss, redistribution, etc., etc. But remember, this is very difficult to treat also. And if you continue PPI and give magnesium, it will relapse immediately. So generally it is said that PPI-induced hypomagnesemia has to be treated by stopping PPI and then supplement magnesium. Then only we can treat. Acid rebound. Well, we all know that PPIs are wonderful drugs. If somebody has dyspepsia, it just gives them wonderful relief. Okay, so if you have got a very good drug and when you stop it, most people develop rebound dyspepsia. Classical example is in a patient with a reflux disease. You give them treatment for 6 to 8 weeks, stop the treatment, within 48 hours they have relapse of symptoms. Because in the treatment of reflux disease, we have never looked at the altered pathophysiology. We have only suppressed the acid. Patient is fine, we are fine, everybody is happy. But the moment you stop it, 48 hours, the biological activity of PPI comes down, acid production increases. Okay, so they will have relapse. So to avoid that symptom, we have sort of taper off. Never ever stop PPI in a patient with a reflux disease all of a sudden. You have to reduce the dose, make it half, maybe another 2 weeks, then alternate days and try to taper off. If they have relapse of symptoms, you increase to the previous dose. This is reflux disease. If you give it for dyspepsia, where it is probably not very much indicated, still the patient feels better. That's why we are giving it. But when you give it to a dyspeptic patient and stop it, they will also develop dyspepsia when you stop it. They in fact get hooked to PPI. That's another problem. It does not produce any addiction or psychical level or mental level issues, but the comfort which they have experienced with the PPI is something phenomenal that they want to continue the drug. when they have mild degrees of rebound after stopping PPA, they complain, and even if you don't prescribe, they will go and take it. That's it. Another important finding is that in various trials, people have used healthy volunteers to know the effect of PPA and various experimental studies. And then at the end of therapy, they found all the healthy so-called normal volunteers experienced dyspepsia when PPAs were stopped. So in fact, when you give PPA and stop it, it produces rebound acid secretion. Okay, there's a mechanism. Because when you give PPA, there's an increased gastrin secretion. The increased gastrin secretion will produce a trophic effect on the parietal cell. In fact, in healthy people, it actually stimulates the parietal cell to grow more cells. Okay, so parietal cell hypertrophy, and it is ready to secrete more acid, but then you are suppressing it by a blocker. Then all of a sudden you block it, all of a sudden you stop giving it. So the hypergastrinemia is persisting. So for a couple of days, this will happen. Okay, so you have to gradually reduce the dose. So if any patient develops symptoms on stopping PPA, never worry, just reduce the dose and try to maintain it for some more days and then gradually taper off. Otherwise, patient will always have relapse when you stop PPA. Bone fractures. This is an area of increasing concern for people taking PPA. Most of the patients taking painkillers, then anti-inflammatory agents for a lot of rheumatic complaints, osteoarthritis. These elderly people know they have lots of pains, and many people will be taking tablets and NSAIDs on a regular basis. And to avoid gastric irritation, most of them are prescribed single or double dose PPA on a regular basis. Okay, so people who take these drugs on a long-term basis, it has been found out that there is an increased incidence of or prevalence of fractures, hip, wrist, and other joints. Okay, many mechanisms have been postulated, and there are many people who believe that these observations are not really very scientific. So there is a hot debate going on whether the risk or fractures are there or not. Many mechanisms are there: diminished calcium absorption, hypergastrinemia, parathyroid. So many mechanisms have been postulated, but various studies have found out that there is actually the odds ratio is towards fracture. Okay, different studies have found out that there is an increased incidence of hip fracture, hip, spine, wrist, and various other things. So there is a risk, but probably we don't have level 1 evidence to say that it will definitely produce hip fractures. Another important thing is that a healthy person may not develop this problem. So most of the side effects of PPA has been found that in a person who are already susceptible, an elderly person, elderly male or female, who is taking NSAIDs and other things, they have already a risk of osteoporosis and other things. On top of it, if you give long-term PPA, their chances of having a fracture is higher due to bone disruption. Another thing is infection. Well, as I just mentioned, gastric acidity is a major defense mechanism, and when you give PPA, the barrier or the security layer is knocked off. Okay, so if you observe your patient, I have noticed couple of times when a patient is put on regular PPA, when he comes back, it's in between, I had a very bad diarrhea. Okay. When I first noticed this, I was also at a loss. I thought, oh, it must be some bad food which you have taken. Finished. But then started repeatedly noticing it that people who are on PPA, when they develop a food poisoning, they almost will have to get hospitalized. Because it will be so bad, severe infection. Not like we eating some food from some place and getting 1 or 2 bouts of diarrhea. No. People who take PPA on a regular basis, and if they get an infective diarrhea or a food poisoning, it tends to be very severe. Why? Because the entire load of bacteria is down into the intestine. Okay, there is no acid to kill the bacteria. So if you look back, or from now onwards, if you just think of this, you may find that your patients taking PPA are actually more vulnerable to develop repeated episodes of diarrheic diseases. And diarrhea due to various agents, starting from food poisoning, salmonella, shigella, and various other things. Okay. And another problem is also, PPAs are also known to affect phagocytosis. So when you give a hefty dose of PPA, the person is also more susceptible to infection because phagocytosis is also affected. So in 2007, a meta-analysis suggested potential threefold risk in enteric infection. So the risk is not just mild, threefold risk. Salmonella, Campylobacter and Shigella. Salmonella and Campylobacter the most common associated with the food poisoning, and Shigella of course colitis. So 2 to 3-fold increase of Clostridium difficile associated diarrhea. That's another thing. So even if you give antibiotics for a short period, if the PPI has been there in the background, the risk of that person developing a Clostridium difficile associated diarrhea is very, very high. Okay, and that is very difficult to treat also. So generally, when you give antibiotics for a couple of days, mostly for acute infection, and only may give for 5 days or even 7 days. Okay, things should settle down. They may develop 2 or 3 loose motion, and things should settle down. Okay, but when it is given on a prolonged basis, especially in ICU patient, broad spectrum, they have the risk of developing Clostridium difficile associated colitis or antibiotic associated colitis, and the risks are much more if there is a background PPA. Especially in ICU setting, we generally give parenteral PPA, and they all have a very high risk. So this also you have to remember. So if a patient develops diarrhea and if it is not settling down, we have to think of this possibility. And of course, testing is very complicated. By endoscopy, we can find out this membrane. Testing for toxin is available. So this is the frequency of infection. So diarrheal diseases, Clostridium difficile infection, Salmonella, Campylobacter, E. coli, Shigella, everything. Okay. So next time you get diarrhea, beware. Don't take PPA. Don't prescribe PPA. SBP. This is one area where I just find fault with my PGs also. Every cirrhotic patient will get I said complimentary PPA. Then I fight with them. Don't give. Because this is a problem. If you give a PPA, the chance of developing a spontaneous bacterial peritonitis is high. We are actually increasing their chance to die. And SBP is a killer. Unless you diagnose SPP within the first 24 hours and give appropriate treatment, they will die. They will die of renal failure, septic shock and other things. Okay. But see, and it's a sheer habit again. You do something, and some endoscopy, some sclerotherapy, this, that, banding, etc. Then try to prescribe PPA. Okay, short course are okay, but prolonged PPA therapy in a cirrhotic is a bad prescription. Okay, so very high PPA use among SPP 69%. Okay. Respiratory infection. Chronic acid suppression may permit intermittent bacterial survival and possible colonization of the upper GI tract, facilitating microaspiration or even translocation to lungs. Well, this again is a very debatable entity. Some people say that the evidence is not that strong, but 2 studies, one from Netherlands and another from Danish study, Sweden, suggested that there is a definite increase in community acquired pneumonia in patients who are taking PPA. Not a hospital, but community acquired. So even community acquired infection is increased in people who are taking PPA. But there have been other studies which have refuted this information also. What about cardiovascular risk? By the time I finish, I think you stop prescribing PPA. Then concerns regarding increased incidence of myocardial infarction, stroke and cardiovascular death associated with PPA and clopidogrel co-prescription. You all know aspirin and clopidogrel are the mainstay for the treatment of any disease where there is a thrombosis. Okay, cerebral, coronary or whatever it is. Okay, this is all thought to be competitive inhibition. Clopidogrel is a prodrug. It has to be converted into active ingredient by the cytochrome enzymes. Okay, and omeprazole is notorious to act on these enzyme systems, and it has been found out that the CYP2 C19, that's the isoenzyme which is required to convert clopidogrel into the prodrug into the active form. Okay, this is the normal, that is C19, but we have variants. C19-1 is the normal, C19-2 and 3 are mutations with less biological activity. So if somebody is normal, and normal means normal genetic genes are there, and there is a good conversion of clopidogrel into the active ingredient. If you give PPA, there is a slight reduction of it. But if the person is genetically affected already, that we have no methods to find out. Now there are genetic testing, either single mutation or double mutation. The risk of that person to have biological activity of clopidogrel reduced to a great extent is very high. So you may give him clopidogrel, but clopidogrel will not be there. So you may think that it is working, but it will not be there. Okay, especially if you co-prescribe omeprazole. But luckily, the newer generation, the rabiprazole and pantoprazole is not having this side effect. It is only the old generation omeprazole and S-omeprazole. Of course, new generation, new avatars come. No, when a drug loses its patency, then new avatars of that drug will come. So S-omeprazole is such an avatar, and you must be careful about that also. Omeprazole and S-omeprazole have the same risk. So in 2007, American College of Cardiology and American Heart Association recommended use of gastroprotective agent in patients with unstable angina, non-ST segment elevation, MI, and who are taking aspirin and history gastrointestinal ulceration. Okay, and with that, then they found out that in their analysis, the people who are taking PPI are having a higher reinfarction rate. That is how people started thinking about it. People who are given omeprazole as a protection are started repeated hospitalization due to more problems due to reinfarction and other things. This is a simple graphical representation of how clopidogrel has to be converted into the active metabolite by P450. This is the enzyme, and omeprazole blocks it. Okay. So now FDA has put the product warning on clopidogrel. The product information for clopidogrel has been changed to recommend avoiding concurrent use with omeprazole because it decreases the antiplatelet effectiveness of clopidogrel. Of course, the latest study in circulation came in January 2015 has refuted this. But the FDA warning is there. I think we are in a situation where initially there was suspicion, then it was more confirmed suspicion, and then FDA said that no more co-prescription of clopidogrel with omeprazole. That is what the American Heart Society and Cardiology Association everything recommends now. But the latest journal has come out with an information saying that probably the risks are not there. I think we have to wait for the next recommendation. As this stands, we cannot co-prescribe clopidogrel and omeprazole. And with this information already available in the net, if we are doing it, we have to be extremely careful. What about gastric polyps and carcinoids? When omeprazole was first introduced, one of the main concerns was that it will produce gastric cancer. That is because in rats it produced carcinoid tumors. When the drug was given in animals, it will be given in very hefty doses, and it produced hypergastrinemia, and carcinoid tumors were definitely there. But in early studies in human beings, this was never found, and then it was declared that this is a safe drug. Okay, fine. But now, when you do endoscopy in patients who are taking PPA, we find multiple polyps in the stomach like this. This is a very common observation now. If you find fundic polyposis, take the history again, you will find the patient has been on long-term PPA. Well, these are hyperplastic polyps. It doesn't become malignancy as such, but I think we should keep our eyes slightly wider open, because this is the beginning. We all have been using PPA for the last 15 years. When we use it for 25 years and 30 years, what is going to happen, we have no idea. Okay. As it stands, we don't have a case report of gastric carcinoma produced by PPA. We have only 3 case reports of gastric carcinoids reported in the world literature probably associated with. That's all. Okay. But when we find polyps like this in the stomach, we have to be a little more careful. It's only a question of time. When we give it for 10 years, 15 years, 25 years, it may evolve into something else. Well, this is another situation. This is a cell-mediated mechanism by which the patient develops acute renal failure. We have no control over it. God only can save the patient. Okay. So all PPA have been associated with acute interstitial nephritis. It's rare, idiosyncratic, and therefore difficult to predict. So if your patient on PPA develops some features of renal failure, raised creatinine, oliguria, something like that, take care immediately and stop it. So in summary, this is a crowded slide, but I would like to say that if you look critically at all the side effects which I have mentioned, I would say level 1 evidence is lacking. Level 1 evidence. But remember that nobody goes and does a study just to prove the side effect of the drug, because the drugs are manufactured by pharma companies, and obviously even if there is a side effect, they are down to sort of hide it. Okay, so it is, if at all a study has to be done, it has to be done by an independent agency. And the drug has to be given on a long-term basis. Okay, so a prospective randomized controlled trial to know the side effect of a drug like PPA nobody is going to do it. So we have to go by indirect evidence. So when we go by indirect evidence, the studies won't be robust. People who criticize the statistical aspect of the study will say that this study has no power, this, that. So many problems will be there. Okay, so all these say that this association is inconsistent. But at two places, they say probably there's a higher magnitude, especially enteric infection. Enteric infection is one area where there is no doubt that PPA definitely increases the risk of enteric infection. Okay. In all other areas, whatever I have said, there are articles which say that probably there is some side effect notice, but whether it is really significant or not, we have to have more studies. Okay. So my conclusions are, when we want to prescribe PPA, prescribe with proper indication. I think that PPI, proper indication. PPA is, the proper indication is ingrained in that word, but we forget it. Okay. It has one of the best safety profiles. You should understand that the drug is really very safe. That's why we prescribe left-handed. And we must also be concerned about the potential side effect with the long-term use. Remember that shorter duration, except for immune-mediated problems, short duration therapy is not with much side effects. Okay, and all of us should be vigilant about the potential side effect, and unless we think of it, we will not detect it. That's it. So we have, especially hypomagnesemia, unless you think of it, you will never find it out. Okay, so we have to think about it, look for it, and if you find it, stop the drug at the appropriate time. With these words, I conclude, and I thank the organizers once again for giving me this opportunity. Should I take questions later?
We can take it last. Take questions last. We take the